Good evening, Sholil sir.
Good evening, sir.
বলুন।
So we need Debmallo and Amitabh to join.
Good morning, sir.
Good evening, Amitabh. How
Good
are
evening,
you?
sir. I am fine, sir.
We still need Debmallo.
Yes, sir.
Is he joining soon?
He will be joined soon, sir.
Right.
I think he's joined, sir. The Roland joined.
Yes, sir.
Good evening, Debmallo.
Mallo, good evening.
Good evening, Sholil da. ঠিক আছে?
হ্যাঁ ঠিক আছে, তুই ঠিক আছিস তো?
তো তুই ক্যামেরার দিকে কেন নয়, তোরটা কি ঘোরানো আছে? ওকে ওকে।
Professor. Professor.
If we have the critical number of participants, let's start off.
Yes, yes, sir. Yes, sir. Professor.
Rajda, I'll call him.
हाँ, सर। सर। हाँ मालूम है, इसीलिए मैं आपको जस्ट ये कर रहा हूँ। सबके साथ एक बार इंट्रोड्यूस करा देता हूँ, सर। Professor.
Yeah.
Good evening, sir. Sir, as you know, sir, we have sir Dr. Shubhankar Chaudhary. He is an eminent professor and HOD Department of Endocrinology and IPGMR and SSKM Hospital, the renowned hospital in West Bengal as well as India, sir. So welcome, Shubhankar, sir. He said, Rupesh sir, he is the moderator for today's views discussion. So
Yes.
we are extremely happy that Dr. Professor Chaudhary with us for today's discussion.
Yeah.
Sir, we have, sir, along with Dr. Shubhankar Chaudhary, we have Professor Sholil Pal. Welcome, sir.
Welcome.
We have, sir, Professor Debmallo Shanal, sir. Debmallo, sir, welcome. Dr. Amitabh Shur, sir. Sir, welcome. Dr. Shayok, sir. Shayok, sir, welcome. And Dr. Shanton Aloy, sir. So we welcome on behalf of Sir Alchem Pharmaceutical Limited, sir, we have welcome for tonight discussion, our views of Galaxy. Sir, just to introduce, sir, our Vice President, Rupesh More, sir, he is with us because he is so excited and I am personally invited that Shubhankar sir, Debmallo sir, Sholil sir will be discussing regarding our lifting. So he is with us. So Rupesh sir also welcome in this discussion, sir.
Thank you very much.
I will not take much more time. I will just give Rupesh sir at least to inaugurate the program
No,
and
no.
hand over the session to Professor
No,
Subankar.
Rajesh, thank you very much. In fact, looking at all this eminent faculty, I was myself excited to be the part of this program, and I would personally thank all of you to being for being a part of this views session. Rajesh, I think it's time, and we have got a substantial number of participants also.
Yes.
So I think that we should start this particular event, Rajesh.
Yes.
So if you can just take charge and start the session, that will be great.
Yes. So, Professor Subankar sir, sir, I'm hand over the session to you, sir. Now is yours. Thank you, sir. Thank you.
Thank you very much. I think we have a wonderful faculty representing not only maybe the gray hair of Sholil Pal and myself, and maybe graying hair of Vimallo to the young brigade. So which will, and of course, all of them, each of them is well established in their own right. And but the younger generation also brings in a lot of fresh ideas. And so we have a good mix of both experience and excitement. And we are talking about this evening vildagliptin. Of course, we all know the importance of glucose control, and especially also in the COVID era. And if we are doing teleconsultation or online consultation these days, I think one of the safest drugs to use to add to an individual with diabetes is possibly gliptin, where you don't have to worry much about attending side effects. Of course, that doesn't mean that it's only vildagliptin. Any of the gliptins, most of the gliptins could fit the bill. But this evening, we shall be talking particularly on vildagliptin, and I welcome Alchem's effort in promoting the science. Of course, commerce is there, but this evening we shall talk mostly about science, but a little bit of commerce will also come in. So if we start with Professor Sholil Pal, who is such a renowned name and is also president of the Diabetic Association of India, West Bengal. So what are your views on use of vildagliptin in combination with other agents? And we all know that traditionally, probably even today, we do start with metformin unless there's a clear contraindication or the patient doesn't tolerate it. But at the second line, while in the past we used to advise a sulfonylurea, there has been a significant shift towards use of a gliptin, or maybe also these days use of an SGLT2 inhibitor. At possibly and the third line, we now would be using an SGLT2 or a gliptin or a sulfonylurea, and then other agents also come in. So what do you see as the prospect of vildagliptin with metformin and with some of the other agents? Would Dr. Pal like to take that up? And we'll have short responses so that we can also have, and how do we have audience questions? Would someone feed us those questions?
Yes, sir.
So-
After discussion, we will give you the question.
Okay, so go on putting those in the chat box, right? Yes, Professor Pal. So vildagliptin and various combinations. And that does not necessarily mean fixed dose combination. Please unmute. Somehow I can't hear you. Still, I can't hear.
Netcast, please.
Maybe do you need your earphones, headphones?
Hello.
Yes,
Ah,
Yes.
yes, yes, sir. Yes, sir. Yes, sir.
Thank you, Subhankarda, for your kind introduction. In fact, we are using gliptin for around 1.5 decades, and as a single molecule and as well as with other molecules. And of this, metformin, along with metformin, it is most widely used. But previously, that is when we are rather younger and gliptin was not that much used, we usually use sulfonylurea and metformin. But nowadays, with the higher risk of hypoglycemia, weight gain, gradually treatment modalities has changed a lot. And now the gliptin is the second, in most of the situations, second agent in the management of type 2 diabetes. It is seen that when one agent is used for the management of diabetes, there is higher chance of gradually failure from the treatment failure. That is, hemoglobin A1C gradually rises after 1.5 years or 2 years. But if combination is used, then it can be maintained for 5 years. It is established by verified trial. And this gliptin, especially vildagliptin, it is seen that it can be used with most of the oral agents as well as insulin, as it is seen from the post-hoc analysis of age, post-hoc analysis. So there is lesser side effect, GI side effects are less, edema are less, weight gain is less. So as a molecule, this can be used from starting from metformin to sulfonylureas, insulin, even SGLT inhibitors, and acarbose. This is my view.
Can I ask you specifically about a combination of a gliptin with an SGLT2 inhibitor? Given the fact that SGLT2 inhibitors, by dint of their action of causing glycosuria, this is known to sort of stimulate endogenous glucose production. Though of course, I must admit, we are not yet clear as to what is the signal, how exactly does it happen. I myself don't know, but it does happen. And gliptins are important agents which suppress endogenous glucose production or hepatic glucose output. So would they be sort of synergistic in action, the combination of an SGLT2 and a DPP4 inhibitor? In of course, vildagliptin will be one example of a gliptin.
Yes, this gliptin and SGLT inhibitor acts synergistically. As of this ominous octet, this gliptin acts in most of these steps, and by increasing renal glycosuria, SGLT inhibitors increases the glucose excretion, so there will be better control.
Okay, and would you like to make passing reference to the age study, which is of course, and the Indian subgroup analysis, which is of course not a randomized control study, but
Yes, yes.
looking at usage in real world scenario.
Pardon, Sugarda?
Yeah, so would you like to comment on the Indian subgroup analysis of the AGE study, which looks at usage of different oral anti-diabetic agents in clinical practice in real world? Oh, right. Never mind. So it of course did suggest that usage of vildagliptin led to better lowering of HbA. And in fact, they looked at different endpoints, a primary endpoint and a secondary endpoint, both of which were not just efficacy based, but efficacy and adverse effect based. So maybe it was done to give a good name to vildagliptin,
Yes.
because the side effect profile is less for vildagliptin. So that both of the primary and the secondary efficacy endpoints, even for the subgroup from India, vildagliptin showed a definite edge over other agents as addition to metformin, essentially. Can I ask, maybe Shayantan, what are your views of use of Professor Pal has, of course, already mentioned that you can use gliptin, including vildagliptin, along with insulin. So what are your views on it? For example, I would, maybe a Puritan, not maybe, some Puritan may say that gliptin acts eventually, primarily, possibly by causing insulin secretion from the beta cell. And if you're giving insulin from outside, what's the fun of using also a gliptin that will also increase the endogenous insulin secretion?
Sir, if we to take the other mechanisms of gliptins, apart from the glucose-dependent insulin secretion, even for, sir, the question actually tells that in an advanced, suppose in a long-standing diabetes or advanced disease, when we are giving exogenous insulin, what is the rationale of giving gliptins, which is mainly a secretagogue, a glucose-dependent action? But since there are some effect on as well as on endogenous glucose production and on suppression of glucagon, so probably if we use along with exogenous insulin, we may get some additional benefit from the glucose lowering point of view if we use gliptins along with insulin, and probably we can have another advantage, that a reduction in the dose of insulin if we add gliptins.
Right, and I may add that there are also suggestions that if you use a gliptin with insulin, you actually may reduce the risk of hypoglycemia. Now that sounds sort of counterintuitive, but at least I do remember specifically with vildagliptin, there was a study which showed that it reduces hypoglycemia. Whether it's with other gliptins, I do not recollect very well. Yeah, Shayo? Yes.
Sir, I was just about to ask you regarding this one, this one, that these gliptins are a group of molecules which, when hypoglycemia occurs, it actually stops blocking that glucagon production. In fact, through the GIP, I guess. So, sir,
Yes.
I mean, what is your view about this one? In fact, I was about to ask you this one.
Yes, it sounds very good. And, there is some theoretical basis, yes, because they increase the level not only of GLP-1 but also of GIP, and we do know that both GLP-1 and GIP cause glucose-dependent insulin secretion. But on glucagon, the actions are different. While GLP-1 suppresses glucagon, GIP increases glucagon in the event of hypoglycemia, low ambient glucose, not when the glucose is high. So that's also will be beneficial. So that's the putative mechanism, I believe, whereby usage of a gliptin with insulin may reduce the risk of hypoglycemia. So that's another advantage, potential advantage of this use. So if we come to Professor Devalo Sannal, who has such a vast sort of experience behind him, but here we will be referring to a study that Professor Sholil Pal has already referred to, the Verify study. So that brings in a different concept. We normally have been attuned to using one drug and then add another and then another. And in this context, the Verify study will hear from you in a little while. But at the same time, probably last December itself, Dr. Ralph DiFranzo's group had been working on this for the last few years on sort of similar mindset, that you start treatment with multiple agents, not just one after the other. So he and his group, of course, there were other members, but we all recall Ralph DiFranzo more easily. So they looked at stepwise usage of metformin, then a sulfonylurea, and then basal insulin, versus sort of shotgun approach of using metformin, a pioglitazone, and an exenatide altogether from the very beginning. On the end of 3 years, they found that the markers of beta cell dysfunction, markers of insulin resistance were much better in this combination treatment from the very beginning. And also the HbA1cs were better, significantly better at the end of 3 years. So what does vildagliptin usage along with metformin from the very beginning tell us, Professor Demal Roshanwal?
Yes, sir. With regards to the first pathophysiological mechanism, which was actually initially advocated by Professor Dufranzo group, where he actually advocated use of GLP and metformin and pioglitazone as well, and that has also suggested to have cardiovascular benefit as well, and they target multiple pathophysiological defects. And if we have similarly with vildagliptin and metformin, which was primarily used in the VERIFY trial as well, we have multiple pathophysiological defects, starting from addressing the insulin secretion pathway with regards to the incretin defect, with regards to the hyperglucogonemia which is there, as well as with regards to addressing insulin resistance with metformin. So we have multiple pathophysiological defects which are taken care of, other than probably the pathway of renal glycosuria, which is addressed by the SGLT2 inhibitors. So this way we can address most of the pathophysiological defects with this combination. And along with that, because it is glucose dependent, the risk of hypoglycemia is less compared to what we were using probably 10 years back more commonly, as well as a first line therapy and a second line therapy with sulfonylurea, and less of weight gain as well. So the main outcome, the primary outcome of the VERIFY trial was whether the combination from the beginning was better in terms of durability compared to single therapy with metformin, what we usually practice. And this was first indicated in the ADOPT trial also, where durability was tested. And what they found out was that the durability of metformin alone was about 3 years compared to about 5 years of durability of vildagliptin and metformin combination, which was about 49% higher. And so that led to so better durability, but also very significant, which is not very often mentioned, which I feel is also very important, is the secondary outcome, which they also evaluated the secondary failure rate. That is, once the metformin failed, then they again started on metformin and up titrated with addition of vildagliptin. And so starting from with metformin and vildagliptin combination versus this gradual stepwise up titration, they also tested. That was also early starting of, starting from the word go with metformin and vildagliptin. There was a almost 30% lower risk of secondary failure, that is addition of insulin, what they used in the in their practice in the study as well. So that is also very important. Not only it extends the durability of effect, but also it decreases the secondary failure, meaning additional use of therapies on top of metformin and vildagliptin. That is addition of third line AD, which is also very important in practice as well. So after that, there has been changes even in the ADA guidelines, where they have added this in a certain population of patients. We can start with this combination. And my personal opinion, especially with this regards, with this 1 year in the pandemic situation, is that a lot of our patients are coming with a very high HbA1c. If these patients are not having overt osmotic symptoms, where I generally would prefer using insulin or sometimes a sulfonylurea, I have been using this combination of vildagliptin and metformin primarily because it is cost effective as well. And in a significant proportion of these patients, I would say after a follow-up of 3 months, most even after a short follow-up of about 1 month, a lot of these patients are well controlled as well.
Right. Dr. Amitabh Shur has not yet spoken, so I would like to to know, the population studied in the Verify trial were individuals with HbA1c between 6.5 and 7.5. Now, if you go by whatever guidelines, usually if the HbA1c is in that range, we are not sort of advised to start on dual agents. So would you be doing starting 2 agents in this HbA1c range?
So even before the verified trial result actually came, pathophysiologically we were knowing it, that it is always better, not just efficacy wise, but also it should be durability wise also if we combine agent, as has been explained by sir also, because of multiple pathophysiologies, I'm not repeating it, which are catered by the combination of DPP4 and metformin. Only thing is, after publication of this verified trial, this has given us an evidence-based outcome that yes, combining vildagliptin and metformin, or for that matter DPP4 inhibitor and metformin right from the beginning, even at relatively lesser HbA1c of say 7.5%, can give us durable response because of the effect it has on multiple pathophysiologies together. And therefore, sir, it has changed our practice principles, I think so, at least for my case. Nowadays, for people who are coming to us with newly diagnosed diabetes, who are having their HbA1c in the range of 7.58%, earlier in such patients, it was our practice to start on single therapy, because at that time only guidelines were there and these were only thought process in our mind. But now, because evidence has already come, so to give the patient the benefit of glycemic durability, we often tend to start patients, barring patients who are very young, young onset type 2 diabetes, barring that category, we do tend to start patients on combination of DPP4 inhibitor and metformin, and definitely because of the evidence is more in favor of vildagliptin, so it certainly has some edge, sir.
Sir,
Right?
sir, I have one question.
Sir, can I add a short remark
Yes.
more, sir? Sir,
Yeah.
something from the previous discussion, that how endogenous glucose production is increased with the use of SGLT2 inhibitor.
Right.
So
right.
can it be because of the SGLT1 as well as 2 receptor expression on the pancreatic alpha cell, and because of which the inhibition that is mainly shown with dapagliflozin, actually not seen very commonly with others, but should be with others also, that inhibition of that SGLT2 receptor at the level of pancreatic alpha cell, I don't know how, but it tend to increase the glucagon production, and that is responsible for the increased endogenous glucose production. Therefore, use of DPP4 inhibitors simultaneously buffers this.
Yeah, it's possible, but only thing, it's mostly been shown to be correlated with the degree of glycosuria. So either if the glycosuria is more, the glucagon level seems to be higher. But of course, this could be a putative mechanism. Thank you very much.
Sir, I have one question.
Yes. Sorry.
Sir, regarding verified trial, in the original verified trial, almost 40% patient on metformin monotherapy, there was no treatment failure throughout the study period. So if we take that, so in clinical practice, since the study entry HbA1c range in Verify was very narrow, 6.5 to 7.5, how to identify that particular patient group which we will get this durability and the cost benefit analysis, because if we put those patients from initial combination, every patient may not need it.
Right. You're correct. In most instances, we are not able to sort of yet go by pharmacogenomics, or that sort of individualized medicine is still not possible in most instances. And because this combination is safe from the point of view of hypoglycemia, weight gain, and so on, and the other point that we are coming to is possibly because today it's available also at a cheaper price.
Right.
Maybe we'll be able to extend this advantage to more number of patients. But of course, ideally, we should be identifying which are the ones who would have otherwise done quite well on metformin alone, and left them alone and used it in the other group. But I think pharmacogenomics or whatever other principles behind are still in their infancy, I would say. So I would like to ask Dr. Shayok Roy. It has been our the general idea that gliptins are not that effective anti-hyperglycemic agents compared to sulfonylureas. So if someone comes with relatively high A1Cs, we still would possibly rely on a sulfonylurea. So how do you compare the glucose lowering efficacy of these two classes?
So of course, we do have this age trial, and I mean, where the combination was tasted, and we do have some other gliptins also, not only Vilda, but of course we do have the gliptin that is a linagliptin in their old Carolina trial, which showed the efficacy that yes, the gliptins can be used, and the efficacy is quite good when you are comparing with glimepiride. So we have the trial right now with other gliptins also. Of course, the main thing is that the gliptins seem to be like when we are comparing that against SGLT2 inhibitors. SGLT2 inhibitors will work when the HbA1c is much higher rather than the gliptins, which will work it's still when the HbA1c is below 8 also. So the thing is that gliptins will need the food in our stomach mostly for their action, and glimepiride is deprived of that. And I mean, so any type of sulfonylurea, mostly. So, of course, sulfonylureas make our HbA1c reduction much faster, much steeper. But again, gliptins with the loss of with the benefit of lack of hypoglycemia risk as well as weight gain risk. Yes, it is a very good option. We can use that when the patients are having a very high HbA1c also. But maybe we might require a small amount of sulfonylurea on top of that to give the final reduction.
Right. So especially when we are combining with metformin, I think the gliptins become fairly powerful anti-hyperglycemic agents as well. And theoretically, we do feel that the durability of action may be longer than for a sulfonylurea, but that aspect I don't think has been so well established. Does Professor Pal, do you have a point to make here?
Yes, Shubhankar, usually the sulfonylureas act in a insulin-independent way. They goes directly inside the beta cell and
glucose-independent way.
Yes, and they cause higher chances of hypoglycemia, especially in the diabetes of shorter duration. So we think that these are more potent, but in long run, their potency is more or less same. And as we have more faith in sulfonylureas, as we are using these, previously we also used sulfonylureas much more than gliptins, and we thought that these are more efficacious. But from study, it is clear that more or less they are same efficacious. And the second point, which was Santan was telling that metformin, why not only metformin? If the diabetes is of shorter duration, say for example, less than 1 year's duration, in that situation, only metformin may be effective. If the diabetes of 2 or 3 years duration, then adding 2 agents is more reasonable, in my opinion.
Right, good. So Shayok has already referred to linagliptin. And when we think of CKD in a diabetes, almost automatically, linagliptin becomes the agent of choice. So what are your views, Dr. Shayantan Rai, on the use of vildagliptin in patients with CKD? because we do understand even if you do not have a kidney problem right now, many of our patients with type 2 diabetes are likely to develop it over the course of the several years in their lifetime. So how safe, how effective is vildagliptin in CKD?
Sir, in patients with CKD, few points needs to be considered. If we take the gliptins which are currently available, only linagliptin and also teneligliptin actually do not require dose adjustment across the spectrum of renal impairment. But for other gliptins,
possibly evogliptin, but of course for teneli and evo, possibly the strength of evidence is not so much.
Yes,
Yeah,
sir.
yeah.
Sir, for other gliptins, need dose adjustment depending on the creatinine clearance. For vildagliptins, it is advised that if the estimated GFR is below 50, use once daily rather than twice daily dose of 50 milligram twice daily, then 50 milligram once daily. Sir, regarding since certain percentage of the drug excreted through urine unchanged and through other metabolites. Regarding, sir, efficacy and safety, we have only one prospective study, that is Lukasevich et al. Study in 2011 in moderate to severe renal impairment. Regarding safety profile, it appears that it is similar to placebo. And regarding, sir, efficacy in moderate, some difference in A1C reduction in moderate and severe renal impairment patients. And only few studies are there in hemodialysis patients in the background of insulin therapy. There also no serious drug-related adverse events like hypoglycemia or liver enzyme elevation happened. So overall, I feel using vildagliptin once daily in patients with renal impairment, mostly moderate renal impairment, is overall safe, and we may get a clinically meaningful A1C reduction for our patients who is having renal impairment. And from cost effective issues, if we use once daily, obviously the cost will be less. And another point I want to add regarding, since linagliptin doesn't require dose adjustment, probably we may be more confident while using it in renal impairment patient, because if the patient don't turn up or sometimes lost to follow up or the renal disease deteriorates, so less concern if we use a molecule which do not require dose adjustment across the spectrum of renal failure.
Right. So that's about renal failure. Can I ask Professor Demallo Shanal about liver dysfunction? Now, even now, if you look at product insert of vildagliptin, possibly they would say that check your liver function and you should monitor it. So what are your views, and is that your practice that you do not start vildagliptin before or without a liver function test result?
With regards to that, sir, even there are studies nowadays coming up with vildagliptin which has shown a reduction in liver fat as well. So we have that opposite spectrum as well. And most of the cases, we don't have a rise in liver enzymes. So, and there is no formal recommendations from any of the societies to do a liver enzyme assessment mandatorily before starting a vildagliptin. But generally, in my practice, what I would prefer to do is at least do a, even if the patient doesn't have a baseline SGPT and SGOT, I would prefer to do it once they come for the first follow-up. Otherwise, if that's fine, I generally would not repeat it in future unless they are symptomatic. That is what I do in most of my patients. So, and in most patients, I haven't seen a problem with use of vildagliptin. Only in patients who have obviously established chronic liver disease, like there is some amount of decompensation, there we generally use insulin. Unless they are mild or moderate, in moderate cases, I would prefer using probably the other gliptin. In mild cases, I do use, because a lot of these patients have some mild elevation in HDPT and liver enzymes. I generally continue using vildagliptin.
So Deballo, your patient that you started on vildagliptin comes back at your first follow-up, and the SGPT is, let's say, 55. The upper limit for the lab is, let's say, 40. So what would you do? Would you stop the vildagliptin? Or
No, sir. I generally don't stop that, because if we at least have 2.5-fold increase in SGPT, generally it mandates stopping of vildagliptin.
Right. So from this point also, I think it's relatively safe, but those are official, the product insert would suggest. And so in CKD, definitely we can use vildagliptin, and possibly using once daily will give your patient a price advantage. And coming to price, this is of course all extremely important for a lifelong disease like diabetes, and many of our patients are from middle or low socioeconomic strata, and even higher up, those who are higher up, most of the time they do not have reimbursement for domiciliary treatment. So if we can get a drug which is effective and relatively cheap, I think it's always better. So can I ask Dr. Shaib Rai, what do you think is the status of vildagliptin in the post patent era, or they call it exclusivity, period of exclusivity? Beyond that phase, what is the role? And we are in a unique position for many of these molecules in our country. Abroad in the Western countries, many times they do not, cannot reap all these benefits that we have. So what are your views?
So firstly, like you said, sir, that our patients, most of them, they do not get the reimbursements. So if you just look into the data of the World Bank, sir, just 1 year back, you will see that in India, almost most of the patients are paying it out of the pocket. And in case of US or anywhere else, it's covered under the reimbursement policies by the medical companies. So that is a big difference when you're treating a patient in US or UK, or you're treating the patient at India, because every Indian, of course, every sort of, including me, if there is an option that the same molecule is available at a lower price, and of course from a good generic molecule, I mean from a good company who makes the quality control standardized, so that you can get the same amount of quality, the same quality of the drug, of course I will always go for that one. And that has actually opened up the era where we can use this sort of good molecules which had in use since the past many years, and we have a huge data behind that. And for many of the patients, just like what happened to your, we can see about our dapagliflozin also, because nowadays we have many patients who are on dapagliflozin. We can use that same thing, the same good benefits of SGLT inhibitors, but at a reduced price. On top of that, if you can use the vildagliptin, which is a very time-tested drug, on top of that, you're getting that at a very cheaper rate. So why not? It has opened up an era where we can use the good molecules at a cheaper rate, and that is of course good for our patients, provided that we are getting it from a good company. Because we all know what happens when you go to any other company. I mean, what happens to the standard of the quality control.
Right. So we have already heard names of a few gliptins by different speakers. So it's now up to Dr. Amitav Shur to give us a comparison of the different gliptins. How does Vilda score amongst the lot?
So, sir, all the gliptins, whether sitagliptin, vildagliptin, or saxagliptin or linagliptin, glycemic efficacy wise, there is hardly any difference between them. All of them produces an HbA1c can cause an HbA1c reduction to a tune of around 0.7, 0.8%. However, there are studies to suggest that at relatively higher baseline HbA1c, when they are used, or in the Asian subgroup of patient, the efficacy of gliptins can be slightly higher, maybe to a tune of around 1% or like that. All gliptins can be used in multiple combinations. They can be used with metformin or sulfonylurea. There is no such contraindication. So far as safety or CV safety is concerned, there are gliptins like sitagliptin and linagliptin, which have definite CV safety data available with them by virtue of TICOS, Carmelina, and Carolina studies. By extension of such CV studies only, though there is no definite CV outcome study with vildagliptin, but we do have a randomized control trial called VIVID trial, which is available with vildagliptin also, in which vildagliptin was selectively used in patients who were having NYHA category 1 to 3 heart failure, which did show that there is no difference between ejection fraction between those who use vildagliptin versus placebo. However, there was some increase in end diastolic volume, the significance of which was not very clear. But anyway, VIVID trial definitely showed that there was not much of a problem with use of vildagliptin even in patients who are having heart failure, NYHA 1 to 3. Saxagliptin and allogliptin are to be taken with pinch of salt, in particularly in patients who were having established heart failure or high risk factors for heart failure, particularly saxagliptin. Allogliptin was something else. It showed increased incidences of heart failure in patients who did not have previous history of heart failure. So maybe some kind of statistical jugglery. So coming to renal outcomes, all gliptins appears to be neutral so far as renal outcomes are concerned. Though we do not have any specific dedicated renal outcome trial with any gliptins. Maybe linagliptin has got some edges, but that edge is also a little controversial, but then it has got some edge so far as albuminuria reduction is concerned. But that's something which is controversial because the outcome was not predefined in that sense. So, in short, sir, all gliptins can be used with a similar confidence so far as glycemic efficacy is concerned. And CV safety-wise, sitagliptin, linagliptin, and maybe vildagliptin can be used for heart failure patients. There is not much of problem with it.
Right. Can I sort of ask you? There's been one study which suggested that vildagliptin has better effect on glycemic variability compared to even sitagliptin. So,
yes, sir.
Amitabh, would you like to comment on that?
Yes, sir. On handful of patients, such study was done between a kind of head-on trial between vilda and sitagliptin, CGMS-based study, in which it was seen that time in range was relatively more in patients who were getting vildagliptin compared to sitagliptin, but did not look much convincing to me, sir.
Right, and I do agree, and if I remember correctly, I think it was an unfair study which compared 50 milligram twice daily vildagliptin versus sitagliptin 50 milligram OD.
Yes.
Have you read this study recently? So I don't think that is quite
Yes,
comparing apples to apples.
Much of convince, yes, sir.
Yeah. So I'll go back to the gray hair of Dr. Sholil. Now, Amitabh has already stated what is there in all published literature that the A1C lowering effect is similar across the gliptins. But there is a perception that vildagliptin used twice daily is slightly more efficacious than the other gliptins. What are your views, Sholil?
So, I think it is more or less same efficacy as when sitagliptin is used once daily, that is 100 milligram, or linagliptin 5 milligram, or teneligliptin 20 milligram. I think it is more or less same efficacy as. I think there is a study they claim that fasting blood sugar reduction is more with vildagliptin 50 milligram twice daily. But in fact, that is again a statistical jugglery, I think.
Right. Yeah. So I asked that because I also tend to feel that vilda twice daily is slightly more efficacious. Of course, I haven't got any significant amount of data set with me to say so. That's just an impression.
Yes.
So I think we have had a wonderful sort of discussion all across. Can I ask once more, Dr. Devmallo Sannal? Already, Amitabh has already referred to the cardiovascular part of it. So, how happy are you to use vildagliptin in patients who may be having existing cardiovascular disease?
Sir, with regards to cardiovascular disease, if you see most of the gliptins, they are cardiovascular neutral in terms of MACE outcome. The cardiovascular death marker, non-fatal MI or non-fatal stroke. So there is no difference, though we don't have any data on vildagliptin with any cardiovascular safety data. But obviously, as Amitabh said, that with regards to the VIVID trial, with heart failure, the area of concern with regards to the gliptin comes with regards to heart failure. And there we have a concern with both Saxa as well as allogliptin, though there are, contentious issues as well with regards to the study population that also we need to take into account. But we have data that there might be some increased risk, especially with saxagliptin. That is not there with Lina as well as with Sita. Now, with in the VIVID trial also, there was no significant decrease or change, and there was a reasonable safety, especially with regards to the outcome. The primary outcome which they evaluated was a change of ejection fraction in patients with pre-existing heart failure, and there was no difference in the ejection fraction, and there was statistically no significant change in death rates between the two groups. But there was one area, as Amitabh said, was the left ventricular end systolic and diastolic volume, which was probably slightly increased in the vildagliptin arm. But that didn't have any significant clinical implications with regards to hospitalization for heart failure, or with regards to death, or with change of ejection fraction. So in most patients, I would feel there is no difference, not any significant difference between Lina, Vilda, and sitagliptin in terms of cardiovascular outcomes as well. So, and
Sure.
with regards to heart failure, they have reasonable safety. I would be put them at par with Lina as well as Sita, but obviously wouldn't be using Saxa and allogliptin in patients with heart failure, or those who have a high risk of heart failure.
For example, for that particular group, possibly today we'll be using SGLT2 inhibitors rather than a gliptin.
Yes.
But one of the unique features, which is generally touted as a negative point for vildagliptin, is that it is to be given twice a day, whereas all the other gliptins are given once a day. And as smart as we Indians are, we have now come up with vildagliptin slow release 100 milligram tablets for use in type 2 diabetes. So who would like to comment on this? I mean, there isn't anywhere else in the world, though initially Novartis also did some studies to look at the efficacy and safety of 100 milligram once a day. But these are slow release preparations. So would Sayantan like to have a go at it?
Sir, obviously, if we use once daily instead of twice daily, it is likely that the compliance is going to increase. And of course, some cost-effective issues will also be there if you use once daily. But if we look at the pharmacodynamic point of view, when we are using vildagliptin from that point of view, we give twice daily to achieve the maximum inhibition post the last dose. But we need to see whether when we are using vildagliptin 100 milligrams sustained release, slow release preparation, whether post the dose, maybe after 24 or 36 hours, whether we are getting the same level of inhibition of DPP4, what we usually in previous studies of twice daily drug, we have the same. My concern is that.
Right. So all of these the products that have come out, of course, has a DCGI or CDESCO stamp of approval, I would believe. And they do look at PKPD studies. And I am sure at the end of 24 hours, they would have shown an acceptable level of DPP4 inhibition. Dr. Shah, yes, you wanted to make a point.
Yes, sir. What I was trying to tell was actually almost like what Shandana said, that we have to look, we have to search for the studies where we have seen the trough level of the DP4 inhibition that keeps on getting inhibited after 24 hours. So what is the level that is maintained? First, how many studies are there? So how did they get the DCGI approval? Because sometimes we see that they just relate like this was going to, this was given twice daily. So once we approve, once we mix them together and give it a slow release preparation, we can get a sort of, DP4 inhibition over 24 hours. But then again, studies are really lacking, sir. So I will be reluctant to use that. On top of that, patients having gastroparesis are really reluctant to use this sort of slow release preparations.
Right, but on the other hand, Shahrukh, you must be using right and left, morning and evening, slow release preparations of metformin. Are you?
Yes, because normally what the type of preparation which I use is, of course, only I do not know whether it is right to say over here the innovator brand only, because they have the studies with them. So I really want to go with the with the companies that have the studies with them. So
Shahrukh will only go with the innovator brand of vildagliptin.
Innovator brand of metformin?
No, not vildagliptin, not vildagliptin. We do not have any vildagliptin innovator brands. Sustained release preparation. The bodies do not have that.
I'm just joking. I'm pulling your leg, trying to pull your leg.
Okay,
so in terms of metformin, so what you're trying to say, they are not the innovators, though. The original slow release or extended release metformin that we have in our country, which is not an innovator brand of metformin, though.
Is there any actual difference if we use sustained release metformin or immediate release metformin in terms of efficacy or side effect?
Yes, there is differences. There is difference. The side effects are less. GI side effects are less. So, what is your opinion?
Yes, I think it's a sort of double-edged sword. So if you look at the upper GI side effects, they may be somewhat less. The lower GI, if you have diarrhea as a problem, possibly that's not much mitigated.
So many patients do complain of diarrhea.
That is a problem of metformin, indigenous problem of metformin, and especially in Bengalis, they do not tolerate metformin well. Gasser problem, Bengali to besi hoy. IBS and
but the whole point is all of the studies, most of the studies that have looked at efficacy, safety of metformin have been with immediate release preparation. With the sustained release ones, I don't think there have been any big studies to talk of.
No big studies, but duration of action is a bit increased and side effects are less. First, when they came, they can demand that it is 24-hour action. But we usually see it is 10 hours, 12 hours like that.
Right. Yeah. So Amitabh, did you have something to say?
So I just wanted to say that what I have seen in my practice that those patients who complain of diarrhea from metformin, they complain of diarrhea at almost any dose. What I have seen is that once a patient will come and say you that diarrhea hoche metformin niye, so sir, however low I reduce the dose, the patient will have the problem. So better to stop it altogether. Secondly, I have seen in those group of patients who do not complain of diarrhea, but they complain of weight, flatulence, dyspepsia and all. For them, either dose reduction or type of conversion from sustained release to immediate. Sometimes both of them work. Sometimes converting from sustained release to immediate release helps the patient. Sometimes the reverse helps, the immediate release to sustained release. So those who complain of flatulence and dyspepsia, they seem to respond by dose reduction or by change in formulation. But those who complain of diarrhea, they tend to complain it even at metformin 500 mg, sometimes even lesser than that. So I don't know why. I have seen this in my.
No, there is a percentage of patients who are metformin intolerant. In that situation, they cannot tolerate even 250 milligram.
Yeah, sure. But I just, though this is not a session on metformin, but since that's one of the commonest drugs that we use, I think in my experience, I differ slightly with Amitabh. I do see that a small, certain proportion of patients who have not tolerated bigger doses of metformin can still tolerate maybe 1,000 or maybe even 500. But let's round up. I think we have an hour discussion about how shall we go on, but it's been so absorbing and so well participated. I do hope our audience also has got a few practice points as well to take back in their clinical practice. Metformin is, vildagliptin is, as a representative molecule of the gliptin class, is a very effective and safe agent to use, and we have seen that it can be used even in presence of severe CKD, of course, where the dose has to be reduced from twice daily to once daily, which also in our context gives us a significant price advantage. It is relatively safe from the cardiovascular point of view, despite the lack of really big randomized controlled trial, but we are all convinced that it is safe from that context. And especially today, we do understand that cost being a major factor, the newer vildagliptins that are being manufactured in our country post-patent are much more pocket friendly, and therefore I'm sure will go a long way in improving the glucose control in our patients. So with these few words, I would like to thank all of our panelists, Professor Sholil Pal, Professor Demal Loshandan, Dr. Shayantan Rai, Dr. Amitabh Sood, Dr. Shayok Rai, for spending their Sunday evening with us, and of course with thanks also to the audience that also chipped in with interesting questions. So back to Alkem, and of course thanks to them for providing this platform.
Thank you, Subhankar.
Thank you, sir. Sir, from audience side, sir, there are two questions. One question, sir, if cardiac safety is major concern, what should be the next pharmacotherapy after metformin?
I've seen that, and we've already discussed on vildagliptin ASAT, the second question that was there. So
Yes.
About cardiac safety, I think maybe what, Demallo, will you like to comment? If cardiac safety is major concern, what should be the next pharmacotherapy after metformin?
So again, the data what we have with regards to most of the recommendations and is that we need to use either SGLT2 inhibitors or the GLP-1, which are recommended either to be used with metformin together, or even they can be considered as first-line therapy, and especially after metformin, either SGLT2 inhibitors or the GLP-1. Especially SGLT2 inhibitors have to be considered in patients with heart failure and especially atherosclerotic cardiovascular disease. If a patient can afford, they can consider use of GLP-1. And so the first line therapy after metformin should be either SGLT2 or GLP-1. And probably we need to consider the other agents like DPP-4 inhibitor. Once the glycemic control cannot be achieved with these combinations, then we can consider them as third line therapies.
Right, and but I would like to reinforce that in terms of cardiac safety, I think there won't be a concern with the DPP-4 inhibitors, at least with vildagliptin, sitagliptin, and linagliptin. So they would continue to be safe, but they do not provide additional protection in terms of cardiovascular disease. Yes. Thank you very much, Demallo. And
as you all know, sir, we have recently introduced our Gluvilda, that is vildagliptin OD, 100 milligrams, sir, at the price of 10 rupees. Sir, actually,
so do you have anyone from your medical department who can now assure the panelists also as to what sort of studies that you have done to have it approved?
Yes,
I am aware, because I have sat through different subject expert committees of CDESCO, that usually you do have to provide pharmacokinetic, pharmacodynamic data. And these are not vast studies. You do on normal healthy volunteers on certain number of studies. So can anyone answer, or Mr. Rupesh More, can he answer?
We have a sir.
Sir, good evening, sir. Sir, in fact, for our Blue-Wilda OD, we are happy to share that we have done the pharmacokinetics as well as the pharmacodynamics trial. So we are not just comparing about the curves, sir, but we have also confirmed that the DPP4 inhibition with vildagliptin twice daily 50 milligrams and vildagliptin once daily 100 milligrams is comparable. So what, sir, this particular data has shown.
And so what Dr. Shayok wanted to know, or others wanted
yes,
to know,
sir,
at
yes,
the end of 24 hours, so what is the percentage of DPP4 inhibition? Is it 80% or what is
sir,
it? Would you remember?
Sir, yes, sir. Sir, with vildagliptin 50 milligrams BID, it is 84.2% over a period of 24 hours, whereas with vildagliptin OD 100 milligrams, sir, it is 84.6%. So over a period of 24 hours, the DPP4 inhibition is comparable. That is what we have checked, sir.
Can you give me the studies, please? Can I get the studies, please?
Sir, we can share that with you, sir. Not an issue.
Thank you.
Shayok, but these are normally not studies published in your peer-reviewed journals, but these are studies which are accepted at these CDSCO or DCGI when they provide these.
Okay.
Yes.
Okay.
Yes.
So at least one of the learning points has been that OD doses or whatever name the vildagliptin once daily are marketed, they have some supporting evidence that they are effective in their once daily avatar. So thank you very much once again, and back to Alkem once more.
Thank you, sir. We thank this opportunity to our Professor Dr. Shubhankar sir for managing the webinar very effectively and ensuring that audience are benefited with this clinically relevant message. We thanks to Dr. Demallo sir, Dr. Sholilpal sir, Dr. Shayantan sir, Dr. Amitabh Shur sir, and Dr. Shayok sir for their enriching clinical experience. We also, sir, thanks to all our doctors who have joined with us for this webinar. Not only that, sir, we salute our doctor, paramedicals who have, sir, contributed immensely for keeping us all safe and, sir, healthy, even at the risk of their own risks in this pandemic situation. We at Alkem Labs, sir, will continue to serve our products available, especially our brand like Blue-Wilda OD, Blue-Wilda, Jupiros, nearby your area. You may reach any time of our colleagues, sir, anytime for reach you for any support. So with this, sir, thank you very much. It was really, sir, effective discussion. Once again, I'm thanks. And sir, those who are not unable to see this view, sir, it is available for those on, sir, YouTube from tomorrow onward. So everybody can see today's discussion, sir.
Thank you very much. Let us all stay safe and healthy. And I think people in the pharmaceutical industry also needs to stay safe. There have been many people in that profession also have been affected, not just doctors or directly paramedical staff. Thank you very much. Very good night.
Thank you, sir.
Thank
Sir,
you.
sir, just a moment, sir. Mr. Rajesh Tigale, sir, he is our GM, sir.
Yeah, very good evening, sir. Thank you. Thank you very much. So I was personally going through all the comments, and we as a pharma people, we also need a lot of clinical experience from your end. That really gives confidence when we promote product to other doctors. And when such a galaxy of experts are there, we are really enlightened with the knowledge, sir. Thank you very much to all, sir. Yeah, thanks to Dr. Shubhankar, sir.
Thank you, sir. Thank you,
Yeah,
sir.
yeah. Pleasure. Thank you very much, and good night.
Thank you.